that is thalassemia. Now, before we start with thalassemia, we all know that what is adult hemoglobin? This part of it you guys have done. It is 2 alpha chains, 2 beta chains, alpha 2, beta 2. I just want to tell you a little bit about the formation and then I can start with the thalassemias. So, when I say alpha 2 and beta 2, that mainly means that there are 2 alpha chains that are present over here and there are 2 beta chains that are present here. So, every chain or protein must have come from a gene, right? This means that the alpha chain had come from the alpha gene and the beta chain has come from the beta gene. But remember, how many beta genes do we have? We have 2 beta genes. So simple, na? 2 genes will make 2 chains. How simple is that? How simple? 2 genes will make 2 chains and these 2 genes are present on chromosome number 11. 1, 1 is 2. So सबको 2, 2, 2 हो गया. 1 and 1, chromosome 1, 1, 11. So 1, 1, 2. So there are 2 genes that are present. They will make 2 proteins. Very simple. Now on the other hand, the alpha gene, you know how many do we have? We have a total of 4 alpha genes which are present on chromosome number 16. 4 4s are 16 na? So how many alpha genes do we have? 4 alpha genes present on chromosome 16 and they are going to make 2 alpha chains. So dekho, chains are always 2 2. Alpha chains are always also 2, beta chains are also 2. But alpha chains are made from how many genes? If I had to write, alpha chains are made from 4 genes, whereas beta chains are made from 2 beta genes. Beta, beta, bi. So 2, 2 and alpha is going to be 4 alpha genes. Now I say that what is alpha thalassemia, what is beta thalassemia? If the alpha chains are not present, that means it is a case of alpha thalassemia. And if the beta chains are not present, it is a case of beta thalassemia. But in terms of the genetics, it's very different. In alpha thalassemia, remember there is alpha gene deletion. Whereas when I'm talking about beta thalassemia, remember in beta thalassemia, there is beta gene mutation. Could you spot the difference between what I've written over here? In one of them, I'm saying it is a deletion problem. In one of them, I'm saying is a mutation problem. This is a very famous question in the paper. But now, how will you guess it in the exam? So note, when I'm talking about alpha, alpha may absent. Alpha thalassemia mein, the alpha gene will be absent, deleted, whereas beta gene is mutated. Mutation means badalna, changing. So in beta gene, it's going to badlo, okay, it's going to change, it's badalna is mutation. So beta gene badlega, that is mutation, and alpha gene will go absent, it will go missing, it will be deleted. Easy to learn? Okay, so what are the questions that you get? How many chains are there? 2, 2, but how many genes are there? 4, 2. Not 2, 2, 4, 2. And 4 alpha genes are present on which chromosome? Chromosome 16. 2 beta genes are present on which chromosome? Chromosome 11. And your basics of the hemoglobin are done. My first disease that I'm starting with is the beta thalassemia. And I've got you a table so that life becomes a little simpler. Beta thalassemia can be divided into thalassemia major, thalassemia minor, which is also known as trait, and something in between, that is thalassemia intermedia. So please note, these are the different types of beta thalassemia. Now, first and foremost, I know in beta thalassemia, it's the beta chain only that is going to have a problem. Beta chain mein problem hoga. So please note over here that when I'm talking about beta thalassemia major, this has no beta chain production. It is going to be beta 0, beta 0. 0, 0 matlab nothing. There is no beta chain production at all, which means the patient is always going to be dependent on transfusion. This is known as the transfusion dependent thalassemia. The patient is always dependent on transfusion. This is also known as the Cooley's anemia. This is also known as the Cooley's anemia. So repeating, beta thalassemia major, always dependent on transfusion, known as Cooley's anemia because there are no beta chains. In beta thalassemia intermedia, few chains are there, little. So I've written beta plus beta plus. Beta plus beta plus means little are missing, little are there. But when I talk about beta thalassemia minor or beta thalassemia trait, you all know in autosomal recessive disorders, trait refers to carrier. So that is going to be, it's one of the genes is going to be totally normal. Beta matlab, if I've not added any 0 or plus or anything, na, sirf beta is written. Beta totally means totally normal. One of them is going to be normal and one of them is going to be little defective. So opposites, one is totally normal, one is totally defective. So that is going to be a trait patient. So remember, when no chain is there, it is major. When little chains are there, it is intermediate. And when it is heterozygous, one normal, one defective, that is thalassemia trait, out of which all of them are going to present with symptoms. Pallor, matlab anemia hai, jaundice because extravascular hemolysis, and splenomegaly, again extravascular hemolysis. Because this is a case of extravascular hemolysis, you see pallor, jaundice and splenomegaly. But beta thalassemia minor or trait patients, sometimes even for an entire lifetime, don't get to know that they have thalassemia. Why? Because they are totally asymptomatic. Look at their hemoglobin level. Their hemoglobin is well above 8. Why will someone above 8, 9, 10 hemoglobin have any symptoms? These patients are asymptomatic till the time you do some tests. So they will come to you for something else. They will come to you during their pregnancy. Females come and they find out that they are thalassemic. They had never known in their life. I have even seen people at the age of 60, 65 getting to know because of some other reason they came to the hospital and then the tests were done and they got to know that they had thalassemia. It's really not going to make any difference to them. When they are 65, they've survived all their life with thalassemia trait without any symptoms. It's not going to make any difference to them. But do their future kids have a probability of having trait or major? That is what is important. It's not about being selfish and what I have, what I don't. What can I pass on to the future generation is also going to make a difference. We'll talk more about it. Overall, we come to a conclusion that all of them are going to come to you with pallor, jaundice and splenomegaly, but beta thalassemia trait has a good hemoglobin, much above 8. It is totally asymptomatic. So, other ones, of course, look at the major wale mein to the hemoglobin is very, very down. It is severe anemia, 3 to 5 gram hemoglobin. Intermediate is somewhat intermediate, 5 to 8 gram hemoglobin, but thalassemia trait is well above 8 gram hemoglobin, so it is not at all symptomatic. Repeating, 3 to 5, 5 to 8 and more than 8. The cutoffs are not important. You just have to know major is more severe, so the hemoglobin is very, very low. Intermediate is somewhat intermediate, so hemoglobin is also intermediate, and minor though is totally asymptomatic, so hemoglobin is almost good. Which out of them is going to show you an increase in the iron profile? That is only going to be thalassemia major. What is the reason? Abhi ke liye rat lo. What is the reason? I shall be coming to that in a while. Also, I will be teaching you what is the HB electrophoresis and the HPLC pattern. So remember that thalassemia major has a lot of fetal hemoglobin, whereas thalassemia minor has HbA2. Ab ye kya concept hai? For these two things, I will have to dwell into the pathogenesis. So let us start. Let me start with the pathogenesis of thalassemia major. Then I will come back to this table and I will answer all your queries regarding this. So the first thing that I start with is beta thalassemia major or intermediate or minor. But before that, their genetics is important, and nowadays there are a lot of updates that have happened in genetics, so you have to know about this. What is thalassemia ka genetics? Beta thalassemia. Most of them are, or many of them can be promoter region mutations. So if you look at any gene, there is a promoter, then there is wo splicing wala portion, exon intron portion, and then chain termination. Yahi hota hai na? There is a promoter region, there is a splicing region, and there is a chain termination region. So any of those mutations can happen. Either the mutation can happen in the promoter region, or it can occur in the splicing, or it can happen in the chain termination. So simple. Out of them, please remember, splicing mutations are the most common. Splicing, what is splicing? What is removed? Going to biochemistry, what is removed in splicing? It is the, yes, introns. Introns are removed in splicing, isn't it? So yes, that is what we are going to do. But over here, the introns are referred to as IVS. Intervening sequences. Intervening sequences is what is going to be IVS. So remember, intervening sequence में क्या mutation है वो थोड़ा सा रट्टा लगाना है. IVS 15G2C is what we see in India. India में most common is intervening sequence 15 codon G nucleotide changes to C nucleotide. So remember IVS 15GC, that is what you have in India. Very, very important thing that you have in beta thalassemia. Most important mutation, most common mutation. After that you have chain termination, which I have told you, तो या तो starting में होगा या splicing में होगा या chain termination में होगा. Coming to the next, we have something known as frame shift mutation. Now frame shift mutation usually occurs at the 8th, 9th codon. It occurs at the 8th, 9th codon, or it occurs at the 41, 42 codon. It occurs at the 8th, 9th codon or 41, 42 codon. Again, something that you'll have to do ratta. Because I was talking about beta thalassemia, I kept talking about mutation, 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 because the concept was in beta thalassemia, badalna, it's always mutations. But now I'll tell you the update, which is the only deletion that happens in beta thalassemia, and that is the 619 base pair deletion. The only deletion that happens is 619 base pair. Very, very, very important set of information that you have. Let's move forward into the pathogenesis. In the pathogenesis, I will be talking about beta thalassemia major first. So what has happened in beta thalassemia major? What chains are missing? Batao, kaun sa wala chains are missing? Of course, I can see it is the beta chains that are missing. So I say that the beta globin chains are missing or have gone down. So now the rule was alpha 2 had to combine with beta 2. But beta 2 to hai nahi. Beta 2 is not there. Beta 2 has gone off somewhere. I am only left with alpha 2 now. So alpha 2 mein what, now this alpha 2 says what can I do? See, now whenever there are two, on a lighter note, I'll tell you two situations. Whenever there is a breakup, there are two things. Either a person in rebound finds someone else to have a relationship with, or the person starts spending more time with himself. Only two possibilities. So ab dekho, beta has gone, breakup to ho gaya. What are the options that alpha has? Alpha says either I will find some other partner or I will spend time with myself. So when alpha decides to spend time with itself, alpha makes alpha 4 tetramers, because see, total 4 banana tha. You had to make a valency of 4. Earlier you had 2 and 2, but now that beta chain is not there, so alpha says I will spend time with my own self, and that is alpha 4 tetramers. Is such a red blood cell going to survive? Which has, can you be like forever single and forever alone and survive? Nahi ho sakta, right? So that is going to be ineffective. This is going to result in ineffective erythropoiesis. This is going to result in ineffective erythropoiesis. Your bone marrow will get very frustrated. Ki I am making cells and then this person is deciding to be forever single and this person is creating a mess out of it. So is there the bone marrow? Is your bone marrow going to say that I will do more and more work to compensate? Your bone marrow is saying I am doing so much of work, you are ruining it by staying single. Hai na? Beta is not there. So bone marrow starts getting frustrated, starts doing a lot of more work. There is erythroid hyperplasia that happens. So this was a possibility that alpha chain said I will spend time with my own self, but that's not going to be successful. The other possibility is that alpha says that I will find a partner, I will find a new relationship. So now it goes and gets into a relationship with gamma 2. What is gamma 2 going to make it? That is going to make it fetal hemoglobin. That is going to make it fetal hemoglobin. Doesn't fetal hemoglobin have a very high oxygen affinity? It is going to have it's going to keep all the oxygen to itself. Will it let any oxygen go to the tissues? Is there going to be a decrease in oxygen at the tissue levels? Yes, there will be a decrease in oxygen at the tissue level. As soon as the oxygen decreases at the tissue level, your body releases what? Your body releases erythropoietin, and erythropoietin will go and do what on the bone marrow? Erythroid hyperplasia. The erythropoietin will make more red blood cells. So repeating once again, one option was staying with its own self, alpha 4 tetramers, wo to waste hua, the bone marrow had to do more work. Second option was combining with fetal hemoglobin. That also is kind of problematic because oxygen will be taken away all from the tissue, because fetal hemoglobin loves oxygen. It will take away all the oxygen and keep it to itself. Again, hypoxia hua to erythropoietin, erythroid hyperplasia. So what are the things that you gather from here? In thalassemia major, did I tell you fetal hemoglobin increases? Have you got your logic behind that? Samajh aa gaya? Okay. Second take home message, did you see that the RBC count is also elevated, which is so weird? It's an anemia. It's an anemia, a red blood cell anemia. I expect anemia hai, matlab hemoglobin is going down, means the RBC count should go down, like it happened in iron deficiency anemia. Iron deficiency anemia mein when the hemoglobin was going down, red blood cells were also going down. But here it is something different only. The hemoglobin is going down, but the red blood cell count is increasing, and that is what is typical of thalassemia patients. Okay, so now the third point that I'm going to tell you, why are the iron levels elevated? That is going to be very, very interesting, because you see your bone marrow is now doing a hell lot of work, either because you decided to stay single or you decided to get into some useless relationship. Your bone marrow is now doing a lot of work. So now when your bone marrow is in a state of erythroid hyperplasia, hyperplasia, won't it tell the gut that, listen, I'm doing so much of work, give me some food at least? Will it tell the gut to increase the absorption of iron? Absorption of iron from the gut is going to increase, from the GIT will increase, yes. So can I say iron levels in the body will increase? Number one. Number two, these patients are always kept on blood transfusion. There are going to be repeated blood transfusions that are going to be occurring. Repeated blood transfusions again result in increase in iron. So all in all, I realize these patients are going to be in a state of iron overload. These patients are in a state of hemochromatosis or iron overload. The reason for iron is also clear. Fetal hemoglobin क्यों बढ़ा? You understood. Why is there erythroid hyperplasia? You understood. Because of erythroid hyperplasia and because of blood transfusion, the iron levels are also elevated. That also you've understood. Now let's understand that despite the bone marrow doing so much of work, like bone marrow is doing extra work, but what are you doing? Ruining everything. Either you are doing ineffective erythropoiesis, or you are making random fetal hemoglobin, or making alpha 4 tetramers, all random things you are doing. Bone marrow is doing so much of work, but you are wasting it. Ultimately, at the end of the day, there is going to be erythropoiesis that is ineffective. So now the bone marrow says, dekho, I am doing so much of work, you are though on some other tangent, you are not making use of my work. Now tell others also to make blood. Why should only I make all the cells? Why bone marrow starts feeling a little left out, that why am I doing all the work? Why are others also not doing the work? Erythropoiesis from all other bones also starts. I've told you erythropoiesis happens in the long bones. Bone marrow long bones ka active hota hai. Now the erythropoiesis is going to happen from all the bones, and this is referred to as not only from all the bones, but it is also going to occur in many organs. So please remember, because it occurs from all the bones, this results in a very famous appearance of the skull, that is a crew cut appearance of the skull. And now you'll ask me that how does crew cut look like? Yes, you can see crew cut appearance of the skull, which is very famous. Either you can call it crew cut appearance of the skull, or you can call it hair on end appearance. It looks like that spiky hairstyle which boys once upon a time was very famous, na? Hair on end appearance or the crew cut appearance, that the thing is there. So question number one, where do you see it? Not only do you see it in thalassemia, you can also see it in other hemoglobin disorders like sickle cell anemia. And secondly, what is it an indication of? It is an indication that erythropoiesis has started in random bones, like even the skull. They have also started erythropoiesis. That is one thing. Other than that, because of this, you will also see a very weird facies. What is that known as? That is referred to as the chipmunk facies. Chipmunk facies is clearly telling you how there is a maxillary prominence that you see over here. There is a maxillary prominence that you see over here. Very important, and that is known as the chipmunk facies. Okay, so that is because all the bones have started doing work. Not only that, why should bones do all the work? What are the organs doing? Sitting vela, right? So the organs should also do some work. Organs also start making blood, and that is known as EMH. What is EMH? Extramedullary hematopoiesis. Extramedullary hematopoiesis, which basically means hematopoiesis, blood is being made but outside the marrow. Outside the marrow means in some organs. So now blood is going to be formed by all the bones, resulting in what all? Resulting in crew cut skull. It is also going to result in the very famous chipmunk facies, right? So the chipmunk facies are also going to happen because of this. So all the bones have started doing work, and second, all the organs have also started doing work, resulting in extramedullary hematopoiesis, with which your pathogenesis of beta thalassemia is over. And in that table, you can all analyze why the iron profile of this case is going to be elevated. You've understood how we are absorbing more iron, how iron is coming from the blood transfusion, and you have also understood why these patients will have elevated fetal hemoglobin, alpha 2, gamma 2. That concept also I have totally explained to you. Ab samajh aa gaya? Now is the entire table falling into place, because I can now show you what are the peripheral smear findings of beta thalassemia major. I'm focusing more on major right now. Beta thalassemia major, I want to take you back to the first anemia that you did in red blood cell chapter. That anemia was microcytic hypochromic anemia, microcytic hypochromic Sita mnemonic. We have not studied the thalassemia till now. Yes, here we go. This is a case of a microcytic hypochromic anemia. This is a case of microcytic hypochromic anemia. You can see, look at the cells, they are looking all empty. They are looking all empty cells, first thing. So first, microcytic hypochromic anemia. Second, I never see, do red blood cells have a nucleus? No, na. Here the red blood cells are having a nucleus. I call them NRBCs. What are NRBCs? They are nucleated RBCs. They are nucleated red blood cells. So all these things over here, these are the nucleated red blood cells. Fine. And lastly, do you see this cell with a dot in the center? This cell with a dot in the center is said to be a target cell, also known as codocyte. It is said to be a target cell or a codocyte. So repeating once again, you see microcytic hypochromic anemia with nucleated RBCs, with target cells or codocytes. T for T, very important. Target cell is seen in thalassemia. Target cell is going to be seen in thalassemia. Very important aspect that you have to know over here. Moving on to the next, what is your confirmatory? I have already told you, HPLC will always be your confirmatory, and you're going to get an elevated of what? You're going to get an elevated fetal hemoglobin. So, of course, you are going to have adult hemoglobin, little bit of adult hemoglobin hoga, but yeah, there's going to be a lot of fetal hemoglobin. More than 90% of fetal hemoglobin is what is seen in the beta thalassemia major patients. But remember, can anything supersede genetics ever? Because this is a very common query I get from students that, ma'am, if HPLC is there, you have told us HPLC confirmatory hai, we marked HPLC, but answer is something else because you did not read the other options. If I say HPLC, of course it's confirmatory, it's the gold standard, but if I say globin gene sequencing is being done, come on. Nothing above genetics. Of course, globin gene sequencing will be better than any goddamn technique on this planet. So this is going to be globin gene sequencing is the best method, of course. But if globin gene sequencing is not given, then my gold standard, of course, becomes HPLC. So it's good to mug up things, but logic mat bhulo. Don't forget common sense in the paper. That nothing is going to be above genetics, of course. This was all about beta thalassemia major, because now I'll come down to that danger thing. Why do I call it danger? Because the patient only doesn't know what he's going to have, he or she is going to have this beta thalassemia minor. This is also that same microcytic hypochromic, but what are the main points that you know? That the patient is totally asymptomatic. So what happens is that very commonly iron deficiency anemia is confused with beta thalassemia minor or trait. Either you can call it minor or you can call it trait. Very commonly. Why are they confused? Because firstly, both of them fall under the same variety of anemias. Both of them are microcytic hypochromic anemias that are present. Okay. So now I say that in both of them the hemoglobin can be 8 or 7. The hemoglobin is going to be decreased. But tell me, which of them is going to have a greater RBC count? What did I tell you? Which of them is going to have a greater RBC? Did I just tell you that thalassemia patients mein RBC count increases and iron deficiency anemia mein to iron hi nahi hai, so when food is not there, then obviously the RBC production will not occur, hai na? Other parameter is RDW. What does RDW tell you? Because RDW is increased in iron deficiency anemia and decreased in beta thalassemia trait. Or you can say rather than decrease, there is nothing known as decrease, you can say it's normal. But hota kya hai? What is RDW? RDW is a variation in size. Think logically. Iron deficiency anemia is a nutritional problem. Iron sometimes will be good in the diet, sometimes will be bad. Sometimes iron is going to be taken in the form of supplements, sometimes it will not. So sometimes when it is good, you have normal size RBCs. Sometimes when iron is low, you have chota RBCs. After few days again iron is good, then again it is bad, then again it is good, again it is bad. So is there going to be a variation seen in iron deficiency anemia? Yes. Whereas beta thalassemia trait is a genetic problem. Once a person is born with it, that person shall die with it. That genetic problem cannot change. Genetics is irreversible. Na? So all throughout it is going to be chota microcytic cells. The RDW will not change. RDW, there's no variation. All of them are chota. It has nothing to do with iron or diet or any of those sorts. So remember, iron deficiency anemia is a lifestyle and a diet related thing. So variation hoga. Whereas beta thal is a genetic thing, so there's going to be the same size all throughout life. Finally, we have an index. There is something known as the Menzer index. There is something referred to as the Menzer index. Please note, Menzer index ka formula is very, very important, and that is M upon R. That is how I have learnt it. It is MCV upon RBC. MCV upon RBC. Please remember, if MCV upon RBC comes out to be more than 13, I suspect iron deficiency anemia, and less than 13, I suspect thalassemia. How will I learn this? You will learn it from today onwards. Instead of calling it thalassemia, you will call it thalassemia. Thalassemia will tell me 13 से less. 13 से less. So less than 13 is going to be thalassemia, 13 से less, and more than 13 is going to be iron deficiency, and there's a logic behind it. Because in whom is the denom? See, both of them, MCV तो दोनों का कम है, because MCV for both of them it is going to be microcytic hypochromic, but for whom is RBC count going to be more? RBC count is more in thalassemia patients. That is why overall index has come low. That's the concept, but exam mein to you don't have so much of time na. You will learn 13 se less is thalassemia. But whatever I had mentioned over here is only and only screening. What is the confirmation of beta thalassemia? Confirmation of beta thalassemia trait, do not forget it. When you get the HbA2 levels beyond 3.5%, mug it up as it is. You will not get, in iron deficiency it will be less than 3.5. Beta thalassemia mein, when HbA2 levels cross 3.5%, and that is what I had written in this table. When the HbA2 levels cross a 3.5%, that is when you do the diagnosis of beta thalassemia trait. Very, very important bit of information that you have to know. So whether you do it Menzer index or RDW or whatever, it was all screening. Menzer index पे बहुत question आता है. MCV upon RBC, you have to know less than 13, I suspect thalassemia. But how do I confirm? Confirm is by doing HbA2 levels more than 3.5%. Rut low, HbA2 more than 3.5%, more than 3.5%, more than 3.5%. You should know that ma'am repeated it a million times and this question is gonna come. But our country is very fond of these screening tests because we have limited resources. So screening tests are done more. And there's one more screening test which is very, very famous, and that is the famous Nestrov test. So that's the last part of beta thalassemia that you have to know. So first you will have to tell me the full form of Nestrov. Nestrov stands for naked eye. This means, that's why it's a screening test. I don't need any microscope. I'm going to do it with my own two eyes. Next, single tube. Single tube. So naked eye, single tube, because I can see there is a single tube in front of me. Red cell osmotic fragility. It is an osmotic fragility testing, and you guys are going to tell me this because I have already taught you earlier. Thalassemia cells are weak or tough? Thalassemia, T for thalassemia. Thalassemia cells are T for tough. So remember this mnemonic always. Thalassemia cells are gonna be T for tough. Means now what I'll do in this osmotic, so everyone's understood the concept. The concept is, it is a naked eye testing. Naked eye means that you are not going to be using any microscope. Single tube, all that you need is a single test tube, and red cell osmotic fragility will tell you that yeah, you are testing the osmotic fragility, and I know thalassemia cells are very, very tough. They are not fragile, they are not weak, they are very, very tough. So what are you going to do? You are going to take these two test tubes in front of you. You are going to take the patient's blood. Patient के blood को हमने test बोला, and एक normal person का blood which is the control. So here you have your patient's blood which is said to be the test. Here you have a normal blood which is said to be the control. तो ये patient का blood, ये normal person का blood. What do you add in the blood? You are going to add saline, 0.35%. So matlab you are basically going to add hypotonic saline. You are adding hypotonic saline. So imagine hypotonic, whenever something is hypotonic, it will start entering the red blood cells. The hypotonic saline will ultimately start entering the red blood cells. Red blood cells will become big, big, big and ultimately break off. Normal cells will break off. Will thalassemia cells break off? No, thalassemia cells are very tough. So what happened? See, dekho kya tha? Normally there were cells. I hope you can see the red color beyond it. These were normal red blood cells. As soon as I added hypotonic saline, these red blood cells started breaking. See, they started breaking. All of them started breaking. So how will I get to know they have broken? I will keep a sheet behind it. I have kept a sheet with some lines behind it. So now tell me something. If the cells were there, normally, agar cells honge, I will not see the line. But if the cells have broken, will I start seeing the line in the background? Yes. So if you start seeing the lines, if the lines are seen, I say that this is a normal sample, because a normal sample will break off in such hypotonic saline. However, thalassemia cells did not break. Thalassemia cells are still standing like this. Can you see the line? Can you see any line behind it? No, the line is absent. So if the line is not seen, if the lines are absent, this means the cells did not break. They were tough cells. They are still standing on the way. You can't see the line. And that is when you suspect thalassemia. So ab na, the mnemonic that I'm going to tell you is going to save so much of time for you. And that mnemonic is, the way you write thalassemia from today onwards is going to make a lot of difference. So you are going to write it as thalassemia. Okay? We are going to write it as thalassemia, which basically means AL for absent lines. What will you see on Nestrov? On Nestrov, I'm going to see absent lines. Lines will not be seen. And what is less that you are mentioning over here? It is less than 13 Menzer index. The Menzer index is going to be less than 13. So repeating once again, the lines are going to be absent. That is point number 1. Lines are going to be absent, and Menzer index is less than 13, and that sorts the entire beta thalassemia portion for you. I hope everyone's been able to gather major, minor, intermediate, clear ho gaya, because now the only thing that we are left with is going to be the other one, the alpha thalassemia. Alpha thalassemia means what chains are missing? The alpha chains are not there. Why are the alpha chains not there? Because alpha gene underwent what? Mutation or deletion? Alpha gene absent hoga. Absent means alpha gene is going to undergo a deletion. So I know how many alpha genes do we have? 4 alpha genes. Now this concept I've told you in the beginning, we have 4 alpha genes, you remember, of course. So this is a normal person, simple. If there are 4 alpha genes, this is going to be a normal person. If only 1 alpha gene is deleted, koi baat nahi, let it be. 1 alpha gene is deleted, so what? I have still 3 remaining, let it be. Let this person be totally asymptomatic, not a worry at all. Coming to the next, 2 alpha genes are missing. This is ATT, so TT, alpha thalassemia trait. This is going to be alpha thalassemia trait. So trait mein 2 genes are missing. Alpha thalassemia trait mein 2 genes are missing. Now 2 genes deletion tak also I was like, chalo, never mind. 3 genes get deleted, I am very worried. Now I'm only left with 1. So if 3 alpha genes are deleted, you will say alpha to raha hi nahi. Now alpha genes are hardly there. Alpha chains are hardly going to develop. So where will the beta chains go? Beta chains also have what option? Whenever your partner goes away, you have 2 options. Either you spend time with your own self or you go and bind to someone else. So beta chain said that over here I am going to go and bind with my own self. I am going to spend some time with my own self. I am going to bind with my own self, making beta 4 tetramers. So how is it spending time with its own self? It has said that, okay, let me distract myself. My partner is not here. I am spending time with my own self. Let me go play golf. This is going to show you golf ball inclusions. This is going to show you golf ball inclusions. Have a look at this picture first and foremost. Why is it looking like a blue washed out picture? Because here you have used a stain called new methylene blue. You have used a stain called new methylene blue, and in new methylene blue you can see these ... wala cells. These are all said to be the golf ball inclusions. Now you know what are the golf ball inclusions. Golf ball inclusions is going to be beta 4. The boy is spending time with his own self. Beta 4. The boy is spending time with his own self. And how is he spending time with his own self? Because by playing golf. He is playing golf and spending time with his own self. And this is seen in which alpha thalassemia? 3 alpha gene deletions wala. 3 alpha gene deletion thalassemia, and this is known as HBH disease. This is known as HBH disease. So please remember, he is a boy playing golf at 3 a.m. to distract himself. ठीक है, what did I say? What is the story? Typical breakup wala story. He is a boy who is playing golf at 3 a.m. Why? Because the girl has left him and gone. So he matlab this is HbH disease. Boy matlab these are going to be beta 4 tetramers. Golf of course tells you that it's going to show you golf ball inclusions. And 3 a.m. क्यों है? 3 a.m. because usually when you have a breakup you are awake late in the night. So 3 alpha gene deletions is what is going to happen in this. ठीक है? So he is a boy who's playing golf at 3 a.m. to distract himself. And that is the story. This is known as the HbH disease. Coming to the last one, when all the 4 alpha genes are deleted, when all the 4, this is not compatible with life only. This is referred to as HB Bart's disease. This is HB Bart's disease and this is going to result in intrauterine death. The child will not survive. There is not going to be any birth. This is an intrauterine death or it is a stillbirth. It is basically a hydrops fetalis wala situation that has occurred. Now HB Bart's is what? Hemoglobin. Think logically. Alpha तो है नहीं. So you will say, ma'am, here also beta 4 tetramers should have formed. No, but I'm dealing with the fetus. Fetus doesn't have beta chains. Fetus has fetal hemoglobin. Fetus was supposed to have fetal hemoglobin that is alpha 2 gamma 2. Now alpha has gone missing. So what will gamma 2 do? Gamma will spend time with its own self. So can I say HB Bart's is nothing but gamma 4 tetramers, because HB Bart's I have learned as barbad fetus. Very bad thing to say, but for mnemonics you have to do. HB Bart's is barbad fetus. Barbad fetus means barbad will remind you of Bart's, and fetus means because this is going to be an intrauterine death, and fetus matlab you have fetal hemoglobin. So remember the method of learning. HB Bart's is going to be barbad fetus. So barbad is going to be Bart's disease, and fetus matlab it was supposed to make fetal hemoglobin, but it did not. It has made gamma 4 tetramers. I hope everyone is okay with this, and we can do a super duper rapid review of all of this once again. When all the 4 alpha chains are there, this person is normal. When only one alpha gene is deleted, that is going to be resulting in, yes, that is going to result in nothing. This is an asymptomatic situation. When 2 alpha genes are deleted, it is alpha thalassemia trait. This is my favorite story. When 3 alpha genes are deleted, he is a boy. So he, HbH disease, is a boy making beta 4 tetramers. How is this boy doing? His boy is playing golf. So golf ball inclusions. At what time in the night? At 3 a.m. in the night. So that is 3 alpha chains or genes that are getting deleted. Finally, if all 4 alpha genes get deleted, that is barbad fetus. What is this barbad fetus that I'm telling you? Firstly, genuinely it's a barbad fetus. When I say barbad fetus, it means it's a case of intrauterine death. Then when I say barbad, it is going to be HB Bart's disease, and it is fetus. So it was supposed to make fetal hemoglobin, but that will not form. So that is going to form gamma 4 tetramers, and that is what you see in alpha thalassemia. With this picture being very, very essential, golf ball inclusions, he is a boy playing golf at 3 a.m. very important. I hope you guys have understood alpha thalassemia and even thalassemias in general, which wraps up what? All your intracorpuscular defects are done. Membrane defects ho gaye, enzyme done, hemoglobinopathy is done, even the acquired one that is PNH is done. All your intracorpuscular defects are done. Now you're left